Good afternoon, everyone, and welcome to the 2018 Brown Bag Webinar Series. This is a series promoting positive patient safety culture and high reliability. My name is Betsy Archer, Senior Director of Grants and Performance Improvement. I'm your hostess today on behalf of Joan Williamson, the VHHA Center for Healthcare Excellence, and the Virginia PSO. Before we begin, I want to go over a couple housekeeping items. The slides were sent this morning via email. This webinar is being recorded. We ask that you please use the telephone option where you'll enter an audio pin. This helps us connect with you and for you to be able to ask questions of your speakers. All participants are muted at this time. We ask that if you have a question, you can chat it into the questions portal of the platform highlighted by the arrow on your screen. You can also raise your hand and you'll identify that symbol that's in the GoToWebinar Grab tab, highlighted in the red box. We'll ask that you hold your verbal questions for our presenters until the end of the discussion. It is now my pleasure to introduce to you Amy Johnston, Clinical Nurse Specialist, and Ava Special, Nursing Supervisor with the University of Virginia Health System. Ladies, turning things over to you.
Thank you for inviting us to share our work with you today. Ava and I are here to present this webinar as frontline team members involved in this work, but really we are representatives of a much larger, highly engaged and phenomenal group of team members that we have the privilege to work with every day. What we will be describing is how our team developed a complete hospital-based violence prevention program here at our institution that aligns with the current recommendations by the Joint Commission and Occupational Safety and Health Administration. It took a tremendous amount of support all across our continuum here to achieve the progress we've made. So I would like to preface by giving a huge shout out to all of our team members who contributed to this large body of work. Also, you might notice the first word on our title slide looks like a typo, but to provide some clarity, SAVE is the acronym we use to describe our team who instituted this work. It stands for Situational Awareness Violent Event. The experience and accomplishments we will be sharing do not include lateral violence or bullying in regards to workplace violence, but rather it is centered on violent patient behavior experienced in the workplace. Our objectives include a review of the components necessary to create a hospital-based program, and to learn the essential team members to include, goals to set, and actions to take. Information will focus on prevention, mitigation, response, and recovery around violence in the workplace. And this webinar is suitable for all healthcare workers, but may be of particular interest to leadership teams who are interested in creating or expanding a workplace violence prevention program. A workplace violence task force was created in response to several significant violent events that occurred in our health system over a short period of time. And we do want to protect patient privacy and confidentiality, so we will not go into any details of these events. But in response to these events, frontline team members started developing and testing standard work that centered around mitigating violent patient behavior. Because of the seriousness and urgency of the need for solutions to be implemented across the institution following these events, the Situational Awareness Violent Event Task Force, or SAVE Task Force, formed in August of 2016. The task force had executive sponsorship from both our Chief Operating Officer and Chief Nursing Officer, which facilitated operational alignment of the work. The task force was also led by quality and performance improvement coaches who helped consolidate grassroots efforts that were occurring at the unit level into institutional drive. Coaches provided guidance on the use of lean methodology for a rapid cadence rollout of newly introduced and developed work to an entire organization. The SAVE task force was guided by 3 key objectives developed following the violent events. These were to reduce team member injuries associated to violent events, to reduce potential patient harm from violent events, and to align to our institutional goal to be the safest place to provide care to patients. 9 specific safety improvement strategies were developed and implemented. The work on these strategies occurred concurrently through small work groups and were introduced from week to week. We used preparedness, mitigation, response, and recovery to drive how we would categorically address violence in the workplace, and met task force goals on a 30, 60, 90-day timeline. A3 methodology, collaborating with frontline staff, and visual management systems were some of the lean tools we used. Senior leadership, including our Chief Operating Officer and Chief Nursing Officer, attended the task force meetings regularly, which helped remove barriers that we encountered. The work relied on a vast array of interprofessional team members from many areas of the hospital, including frontline nurses and team members from the areas that were impacted by the violent events preceding this work, emergency management services, marketing, security, nursing professional development services, patient safety and risk management, physician representatives, the chief officer of the patient experience and environment of care, and many, many others. Over the next few slides, we will take a look at the work completed by the task force. The first piece of work tested and implemented centered on preparedness, and we included the use of visual markers at the doorways of patients who had a potential for violent behavior. The stop sign was developed to be used for any patient exhibiting signs of aggression or potential for aggression that may lead to team member injury. Some of the triggers for identification of potential violent behavior will be discussed in more detail in just a minute, but this visual cueing system helps to identify and communicate to team members the need for a safety approach when entering a patient room, which helps to decrease the likelihood of team member injury. The stop sign helps alert all team members of the potential for violent behavior, including those who may not be a part of the direct clinical care team, such as phlebotomy, therapy, nutrition, and housekeeping. The next set of strategies focused on mitigation. We incorporated visual markers for potential of violent behavior to be used in the electronic medical record. These visual markers in the EMR help to share information about potential for violent behavior in an obvious and expedited manner. This particularly helped close the gap on information sharing between inpatient and outpatient settings. A flag can be set by anyone with EMR access, including registration, emergency department team members, and bedside nurses, and documentation of possible future risk helps provide consistent care for the patient while maintaining the safety of the team. Risk management and patient safety staff use a weekly report to identify new flags and change them to a permanent status when appropriate. EMR identification helps team members that are not part of the immediate care team to be aware of possible risk and institute possible safety strategies prior to providing care to the patient. The flag appears as a banner across the screen when the EMR is opened. So the yellow yield flag signifies low-risk behaviors of verbal aggression, whereas the red stop flag indicates high-risk behaviors, in other words, physical aggression. Whenever a behavioral stop or yield flag is entered into the EMR, a behavioral flag note is also placed. The behavioral flag note includes a description of why the flag is warranted, the frequency of which behavior occurs during a shift, and how the behavior is best mitigated. This provides valuable information to future caregivers who might interact with the patient. Next, we reviewed our threat assessment process and created standard work for team members. A threat assessment can be requested by any healthcare team member who has a reasonable belief that an individual or a situation creates a threat to potential harm or others. Hospital security, police, unit leadership or the nursing supervisor, the patient's nurse and attending physician, and the shift manager of the unit huddle and agree on a collaborative safety plan to mitigate threats. The SAVE task force changed the process of requesting private security for specific patients so that frontline team members can request private security at any time without the need for leadership approval. Standard work was created around this process, and many team members have expressed how this has made a huge impact in their ability to deliver the best care during some of the most challenging of circumstances. The next batch of work focused on response efforts. A SAVE call script was developed to assist the team member when calling for one of 3 behavioral response needs: the Behavioral Emergency Response Team, or the BERT team, security, or an explosive violence response. The clinical, security, or police response to a SAVE call can be just the BERT team and police, security only, or security and police. By providing information in 6 scripted phrases, the team member helps the hospital emergency operators to dispatch the correct response as quickly as possible and reduces call time spent on the phone. And that brings us to restricted access. Prior to the task force, the only units in our institution with restricted access were the behavioral health unit and pediatric units. But with the work of the task force, intensive care and intermediate care units became restricted access 24/7, as it was recognized that those care settings are more likely to experience visitors with higher stress levels. Acute care units implemented routine nighttime restricted access with the ability to restrict access at any time by pushing a button if a violent event occurred on that unit or on a unit in close proximity. Standard work was created to assist with these changes, and our marketing team also developed visual aids for patients and visitors utilizing the unit doorbells. Next, the call for an explosive violent event was created with standard work on how to respond when an event is called. In response to the violent event overhead announcement, team members are expected to have a heightened sense of awareness, to shut unit doors by pushing the restricted access button, to initiate emergency procedures when a threat is identified, such as drawing the curtains, turning off the lights, silencing phones, being quiet, staying out of the line of sight, and placing barriers as appropriate, and to direct non-unit team members into a safe area, such as a patient room, storeroom, or out the back door. The run, hide, fight mantra used for active shooter situations was also adopted for team member use when encountering a violent situation. And at this point, I am going to hand it over to Ava.
Thank you, Amy. Hello, everyone. I'm going to pick up where Amy left off and speak to how we incorporate recovery after a violent event. After an event occurs, the hospital resource support team may contribute to the recovery process by relieving team members involved. An after-action review is completed after every explosive violent event as well. Emergency management, unit leadership, the patient's nurse, the attending physician of the patient, security, and university police participate in the after-action review. The review usually takes place as soon as possible after the event is over. Perishable information is collected, along with any opportunities for improvement. Faculty and Employee Assistance Program, or FEAP, is offered to team members, and a representative from FEAP may attend the after-action review with affected team members. For education, we used computer-based learning programs and a live class to teach increased situational awareness and the SAVE standard work, with a nursing completion rate of 99.6%. Since it was first introduced, this education has been included in orientation for all new team members hired to the institution. As new standard work was developed, Be Safe bulletin emails were distributed. We found that after the education was shared, threat assessment volumes increased significantly and SAVE call durations decreased. These graphs show the increase in threat assessments by almost triple and a decrease in call time for SAVE calls by 5%. The SAVE task force also participated in a Gemba walk to collect feedback from frontline team members around the standard work and to assess team member learning. For easy access, a desktop icon was created to house all of the SAVE standard work, in addition to important phone numbers and links to applicable policies. The SAVE desktop icon can be found on all shared computers throughout our institution. Here is a screenshot of the opened SAVE desktop icon with links to standard work and SAVE resources. All of the work we've reviewed thus far was completed in a relatively short amount of time, as displayed here. During this time, it was recognized that the SAVE task force work would need to continue, and the task force transitioned into a permanent work group. Participants in the permanent work group include neuroscience administration, call center leadership, patient experience leadership, risk management, chaplaincy, environment of care leadership, pediatrics leadership, and ambulatory leadership. Some of the work completed thus far includes: we created new standard work to initiate threat assessments in the emergency department for victims of non-accidental trauma. This allows for security and police to assess a situation and determine if a visitor restriction is necessary to keep patients and team members safe. By performing the threat assessment prior to admission, potential perpetrators of violence are prevented from accessing the area where the patient is located. Next, to facilitate communication between private security officers, nursing team members, and hospital security officers, a private security duty checklist was developed. This provides a better understanding of the expectations for private security officers in the hospital setting. A SAVE badge was trialed on 3 different inpatient units: an acute care neurosciences unit, a surgical trauma ICU, and an acute care pediatrics unit. The SAVE badge is a wearable alert button that clinical staff use to alert their team members when they encounter violent or threatening behavior. We tested team members' perceptions of safety by using surveys prior to, during, and after the 1-month trial period. Currently, our behavioral health unit and our acute care neurosciences unit use the SAVE badge. We implemented 24/7 information desk coverage to assist with after-hours visitation. We also developed SAVE visitor restrictions for patients who are victims of non-accidental trauma and whom require visitation restriction for patient and team safety. The SAVE restriction alerts information desk and call center personnel to these sensitive patient situations. For when an explosive violent event occurs, pop-ups on computer desktops alert all team members to initiate explosive violence response procedures. We continue to review visitation management for how to keep our patients and teams safe while providing visitors access to support their loved ones 24/7. We conduct explosive violence and active shooter drills on a yearly basis. This past year, Drills were performed every shift over a one-week period to allow maximum participation from all team members. Finally, a 4-hour workplace violence prevention and response course was developed through collaboration between the SAVE work group and emergency management. This course is available to all team members and provides education on situational awareness and response to violence in the workplace. Some of the learnings from the SAVE work include failing to report or underreporting of workplace violence, changing the culture around workplace violence, keeping team members current on education and resources available, and difficulty with compiling and measuring workplace violence data due to underreporting and lack of a standard national benchmark to utilize for comparison. However, on the next 2 slides, we will share how we are improving on these challenges. Despite the challenge of underreporting, we have found an increase in reporting at our institution since introducing the SAVE work, as displayed here. This slide shows an increase in the number of RN assaults as a result of workplace violence reported through our Be Safe event reporting system. This increase in reporting of workplace violence events reflects a slow forward motion in cultural mindset of workplace violence being just part of the job. In working with our data analyst team, we developed a way to quantify outcomes through a calculated rate of injury. This graph is reflective of the positive impact of the SAVE work. Here we see a decrease in the RN assault from workplace violence injury rate after the SAVE work was introduced. The application of lean methodology in all of our work helps to ensure that we address root causes and that through the methodology, we ensure the use of data to drive continuous process improvement. We would like to take a moment to speak to how our work has aligned with the Occupational Safety and Health Administration guidelines for developing a workplace violence program. Displayed on this chart, you can see the OSHA guidelines on the left side with what we've done in our SAVE program on the right. When we transitioned to a permanent work group, one of the first action items addressed was the development of a program charter. The charter defines the scope of the work and clearly describes our objectives to protect team members from injury from violent events. It was also decided that the SAVE work group would report through the Safety and Security Subcommittee. The SAVE work group continues to have executive sponsorship, including our Chief Operating Officer and Chief Nursing Officer, is directed by administrative leadership, and is inclusive of interdisciplinary team members. A lean methodology coach continues to guide our work. All safety risks and events are discussed during huddles at shift change on the unit level. The huddle is our mechanism of identifying safety concerns that need to be escalated to senior leadership for real-time problem solving. Gemba visits to work sites have been performed to assess for environmental hazards. Organizations similar in our size and scope were visited to learn opportunities for improvement and to aid in pre-planning for environmental redesign, including new construction. Our mitigation standard work, situational awareness education, and new building design addressed identified hazards. Training occurred using a multimodal approach with various classes, bulletin messaging, simulated training drills, and testimonial videos. We use data to drive continuous process improvement of our program through a weekly review of events, team member injury data tracking, and an annual program charter evaluation. In summary, we have found the following items on this slide to be critical to success in a workplace violence program. Engagement and participation from both frontline team members as well as leadership is necessary throughout the development and maintenance of a workplace violence prevention program. Focusing on preparedness, mitigation, response, and recovery provides structure when setting objectives. Lean methodology, such as using a 30, 60, 90-day timeline, use of root cause problem solving, collaborating with frontline staff, visual management systems, and Gemba walks adds to program efficiency. Actively engaged team members, accurate reporting of workplace violence incidents, and continual education of all staff is necessary for program success. Workplace violence in healthcare remains a persistent challenge. A continued effort is needed to ensure a safe environment for patients and visitors and a safe workplace for healthcare workers. We want to thank you for allowing us to share our journey with you, and we want to open it up to any questions.
Ladies, an excellent presentation. I'm going to have Teresa take a look at what questions are coming in. And we do have, well, we have a comment and a question. First, great work and great presentation to you, ladies. And the question is, what role does private security play?
So for some of our higher level patients that are at risk of some violent behaviors, we find that their needs exceed what we can provide them with our companion resources. And so we'll have a private security officer at the bedside just as an extra level of security. And we also utilize private security for some of our sensitive patients who have experienced non-accidental trauma, usually in a situation in which the perpetrator has not been apprehended by the police. And that allows us to have an extra level of security at the unit level. So they might be outside of the unit, even though the unit can be unrestricted access, just an extra person to check visitor passes and make sure that the right people are entering the unit.
Okay, great. I don't see any questions coming in now, but would like to remind our participants that you can go ahead and chat in your questions into the questions portal of the GoToWebinar platform, or you may raise your hand and you can verbally ask questions of Ava and Amy. And while we're waiting for questions to come in, I want to let you know that there will be a survey, a very short 5-question survey that will pop up and get your feedback at the conclusion of the webinar, and we appreciate you taking the time to provide your input. Well, ladies, I don't see any additional questions. There are no hands raised, so that lets me know that you covered it very thoroughly. Thanks, everyone, for your time today, and we'll see you next month for the Brown Bag series as it continues. Thanks so much.
Thank you.
Thank you.